A clinical trial is being conducted to evaluate the safety and efficacy of a novel therapy to treat refractory Crohn's disease. Always remember, refractory is one thing which does not respond to traditional medical treatment. Crohn's disease and ulcerative colitis are basically a type of inflammatory bowel diseases. And efficacy, I have told you, it is a maximal response that can be elicited by a drug. The medication is a monoclonal antibody against the A4137 integrin, which inhibits the migration of T lymphocytes into the intestinal parenchyma and produces a gut selective anti-inflammatory effect. Patients who have active, moderate to severe Crohn's disease and have failed conventional therapy are enrolled in the study. Many of these patients have renal or hepatic dysfunction. Renal or hepatic dysfunction. And some take other medications that affect cytochrome P450 enzymes. Which of the following is the most appropriate dose adjustment? First, as I told you, whenever you read a question stem, let us first understand what we already know. Whenever you go through a question stem, USMLE, NEET PG, any exam, what we already know. So what do we know? We know that monoclonal antibodies are used to treat a growing variety of malignant leukemia, lymphoma, melanoma and autoimmune disease. They are used for these two purposes, autoimmune and cancers. The therapeutic effect is achieved by binding to their target antigen in the plasma or on the cell surface and blocking the receptor interactions. They act by blocking receptor interactions. Either they block receptor interactions or they trigger a cytotoxic immune response. Cytotoxic immune response against abnormal cells. Either they will block receptor interactions or they will trigger a cytotoxic immune response because of their large molecular size. They have an extremely huge molecular size. They cannot be administered orally. Often it is asked that why monoclonal antibodies cannot be administered orally. One of the favorite questions on USMLE or NEET PG, and the answer is extremely simple. Because of their large molecular size, they cannot be given orally and they must be given by intravenous, subcutaneous or intramuscular route. Unlike most other drugs, these are, now this is extremely important, not eliminated by hepatic or renal clearance. This is what we know. They are eliminated in two primary ways. Number one is target mediated drug clearance. Target mediated drug clearance. Monoclonal antibody directed against cell surface antigens, they undergo internalization, that is receptor mediated endocytosis upon binding to the targets, removing them from the circulation. And the second one is non-specific clearance. Non-specific clearance. This immunoglobulins are constitutively taken up by the reticuloendothelial macrophages. Reticuloendothelial macrophages via binding to the F receptors, Fe receptors to be specific, and vascular endothelial cells taken up by reticuloendothelial via and vascular endothelial cells via pinocytosis. And once they are internalized, they are catabolized into amino acids by lysosomes. So this is all we know about monoclonal antibodies. Now let us take a look at the options. Higher dose in patients taking cytochrome. This is all obviously wrong because many drugs undergo modification. But immunoglobulins are not metabolized by these enzymes, but they are broken down by proteolytic enzymes, which I already told you. So choice A and C both are wrong. Because liver cytochrome P450, so here no role at all. Then B and D, lower dose in patients is decreased. Again this is wrong because immunoglobulins are too large. I told you to undergo substantial filtration at the glomerular basement membrane, also known as a GBM, and they are not secreted by the renal tubules. Therefore, renal dysfunction does not significantly affect monoclonal antibody clearance. Fine. E, no dose adjustment necessary. This is the correct answer. Diagnosis of exclusion.